I hold a board of directors seat on the American Academy of Clear Aligners. Again, I have a frozen PowerPoint. Clear aligner culture. In a typical office, there are needed services and there are value added services. Needed services, what I call fillings, crowns, implants, root canals, perio, all the things that we've been doing for 100 years in dentistry to feed our families. And there are things called value added services, what I call, the things that you sell above and beyond what people need. Tooth whitening, Rotodent toothbrushes, Sonicares, Oral-B's, and clear aligners were in that category for a very, very long time. Clear aligner culture mandates that you put clear aligners from the shelf of a value-added service, take it from beside the whitening and put it into the realm of needed services. What is a clear aligner culture? A shift in your mindset whereby clear aligners are a needed service. Clear aligners are diagnosed and treatment planned for periodontal health, occlusal function, and occlusal harmony and stability. Tonight, we're going to give you an intro to the playbook, some tips and tricks, and we'll have time for a brief question and answer period. The playbook consists of definitions, case selection criteria, where our cases come from, brief treatment planning considerations, how we deliver care, monitoring of our patients, and how to avoid the Black Mariah, what kills the game in clear aligner world. If you want to jot down the dates of the upcoming courses, to comprehensive course on clear aligners, Toronto, Chicago, and recently Dallas, Texas. Session 1 in the fall, September in Toronto, October in Dallas, and November in Chicago. And session 2, Dallas is session 2 in December in Toronto, in January, and finally Chicago in March. So if any of those fit your schedule, please call 877-372-7625 to register, or get a hold of Lee at rondeauseminars.com. In our 4-day course, which I encourage everyone to take, simply put, I give you the playback to input this into your office on Monday when you get back. All techniques, tips and tricks, A to Z. And my goal for the participants is to know more about clear aligners than any of your colleagues. And that goes for other practitioners that are delivering care, maybe specialists that are delivering care. Rondeau mandates that we hold education, we hold you to a high standard in terms of education. We want you to be, this is not a gimmick. We want you to do it the right way. We want you to do it the proper way. And we want you to be highly educated in the methodology of clear aligners. Right now, everyone in Zoom world is thinking about reasons why this won't work in your office. And let me help you. Let me kick this off by saying dentists give themselves roadblocks. We automatically think why we can't do things, okay? First feedback I always get when I talk to doctors about doing more Invisalign in their practices, our office is busy enough. And that drives me absolutely insane, because I've come to realize after 3 years of doing this at a high level that the minimum criteria for entering clear aligner culture is having a busy office. You can't shut down your doors from general dentistry and decide one day you will be offering clear aligners and nothing else other than clear aligners. Your patients have to come from hygiene. So minimum criteria to get in this game is a busy office. I learned from Brock Rondeau, day 1, session 1, hour 1 of intro to comprehensive orthodontics, that we have an advantage as general practitioners, that our patients come from hygiene, and clear aligner world is no different. I hear the argument, I don't do ortho. I have hundreds of colleagues in the AACA. I monitor dentists. I mentor dentists, around Michigan, and I don't hardly know any of them that do orthodontics, straight brackets and wires in their office. Moving teeth in plastic is a GP product. Moving teeth in plastic is a GP discipline. Orthodontics can be trained to be done by, to a general practitioner, but it's the realm of a specialist usually but unless you take Brock Rondeau's course. But in clear aligner world, I don't do ortho. It does not preclude you from doing Invisalign at a high level. Our patients will never go for this. This is a stumbling block of team members that like to think that the patients are set in their ways. They're never going to go for treatment. But we have a methodology whereby we diagnose and we present in terms of health, function, periodontal health, overall health, systemic health. And we notice in private practices that we gain more traction in patients that we never thought would go for clear aligner therapy when we present it in this way. I've heard that the scanning, the iTero costs too much, the scans cost too much to submit, the lab bill is too high, the staff cost is too much. Everything in the dental office is attached to overhead. Everything is a high overhead procedure in the dental office. Invisalign is no different. But when done properly, it absolutely makes a huge difference to your bottom line. I'm too old, I'm too young. We work in a small city, we work in a big city, and clear aligners don't work. I've heard all of the roadblocks, and I'm here to dispel them one by one. But I only have an hour. So change is hard, but change is necessary. Change requires taking you out of your comfort zone, and it requires breaking down your barriers. Every 10 to 15 years, something new comes up and changes the way we do things. Case in point, Rachel, my assistant, 23 years old. She's pointing at not the reflection of the exit sign. She's pointing at this little tiny red light. I'm not sure if my mouth shows up on the screen here. She's pointing at the tiny red light above the door. Hey, doc, what's this? Well, Rachel, we used to have a dark room a long time ago. We used to develop x-rays. We used to have the door shut, the lights had to be off, and that red light would tell you not to open the door because we're developing x-rays. Wow. Are you serious? That's what she told me. Yes, unfortunately, I am serious. That's the way you used to do things. If we were to show up at a job interview next week for a dental job, any position, be it dentist, hygienist assistant, okay, and we came across the doctor that said, can you take good radiographs? I really, really like good, sharp, crisp radiographs. You would say, yes, I can. And you're expecting to see something like this, like on a computer screen, computerized digital radiography. But what would happen if instead you saw this? You saw an old dip tank, or this, the old processor, or this from the dental school clinic floor. If you were to see this, you would run the other way. You wouldn't want to work in an office like this. My job interview in the year 2000, when I graduated, they said, hey, doc, your resume looks really good. Looks like you know what you're doing. We think we're going to hire you. We want to show you our new charting system. I said, charting system? What'd you get, Dentrix? Did you guys get EagleSoft? No, we got this and this. And there's so many pieces of paper that you can add. So this office had upgraded to a paper charting system when I was clearly expecting computers. And what if you went back in time and you opened up a lab case and you were to see this nice anterior bridge with a gold, metal collar, okay? What if this was the standard of care of aesthetics? This after doesn't look any better than before. But what if this was all aesthetics had to offer back then? What if you could tell that doctor, listen, one day we're going to have metal-free aesthetics. Even better than that, we're not going to have bridges anymore. We're going to have crowns that go on top of these screws that you put in the jawbone. All of these offices had to change. All of these doctors and their teams were busy enough at one time when they were using the dip tank or they were doing anterior PFMs. All the workflows were adequate. The doctors were doing very, very well. Team members were happy, okay? And nobody wants to rock the boat. Nobody wants to do something new that causes stress and frustration, okay? But in 2023, all of these things are obsolete. None of us, within reason, do any more anterior PFM aesthetics. No one has dip tanks anymore. Digital x-rays are universal. And paper charts, most of us are charting on computers, okay? And if you went for a job interview in any of these places, you wouldn't work there and the doctor would have a hard time finding great team members and he wouldn't have any patients either, okay? This is what change has done for me. This is my growth curve up until 2021. And I'll tell you, in 2023, it's up even higher, okay? My progression has been the incorporation of a scanner. My progression has been due to a class called Reengage in the AACA. And my more recent growth has been because I kept buying iTero scanners. I now own 3 of them, and they're pumping all day long scans. I'm a 4-time platinum provider on my way to 5 times. I'm a single practitioner, which is a big deal to me. I own a single office. I don't cheat and run other people's Invisaligns under my account. And I have 0 social media game. And I'm not joking when I say that, because this, up until very recently, was my social media. My dog and my kids putting, I don't know, gummy worms or something on my face. Okay. Clear aligner culture, diagnosis based on periodontal health, function, occlusion, and way last aesthetics. Okay. Here's a case that I did on a nice lady. This is her before, and this is after. But more importantly, this is her face before, and this is her face after. That is quite a change. Okay. She came into the office and says, "Doc, I need to show you. I got 50th wedding anniversary pictures done. I need to show you." So here is her wonderful, beautiful smile on her 50th anniversary. This picture is my favorite picture because she's looking at him, as if she makes him the center of attention. But all I can focus on is her teeth, because they're nice and they're bright and they're straight. And just knowing her personality and how bright she is after we did Invisalign treatment on her means the world to me. Okay. Mission statement from the AACA: a healthy smile enables a person to reach their maximum potential in life. Spoken by Dr. David Galler, president of the AACA. Benefits to the patient that come in the clear aligner culture are measured based on occlusion, function, perio, oral health, and lastly, cosmetic. Let's take a look at this case of lower anterior teeth before and lower anterior teeth after. Expansion in IPR, meaning mild interproximal reduction using sandpaper strips, 12 weeks. Let's play this out here. Expansion in the maxillary arch, premolars forward, IPR, a tiny bit of lingual retraction, and case solved. Okay. Lower required a little bit heavier IPR. This is how it plays through. Mild expansion in the premolar area, 12 weeks, and she was done. Here's her befores, here's her afters, a world of difference for her. But I ask all the docs that I lecture to, what is the best part about this case? Was it her perio improvement? No doubt she's improved a great deal. Was it her functional improvement? Well, she now has canine guidance. Does she have adequate space for an implant? Absolutely. Is it her protected occlusion with proper guidance and proper overjet and overbite? No doubt. But none of the above was the most important part. The most important part of this case was going from here to here. The before tells a story, but the after tells much more of a story, in my opinion. And this is what I'm addicted to, and this is why I do what I do. How does your patient benefit? Of course, functionally, occlusally, periodontally, overall health, overall oral health, overall systemic health, and last on the list, cosmetics. Functionally, what the patient can't feel, things like abfraction lesions, changing the axial inclination of the teeth so that you're dissipating the forces down the long axis, overjet and overbite, and establishing a canine protected occlusion, and even parts on all parts, even contact on all parts of the tooth versus point contacts and chiseled in occlusions, okay? And occlusally, I call what the patient can feel. Oftentimes they comment about how great their bite feels, and they never realized something was wrong beforehand. It's the number one comment that I get. Here's a gentleman that has what I call the chiseled in occlusion. So in centric relation, he's in contact on the right side, wide open on the left-hand side, okay? And this is after. Here's a more up close look of his before on the top, his after on the bottom. Very, very quick, easy treatment. Here's his occlusogram. Occlusogram is a function of the iTero scanner where you turn on these occlusal hotspots, and it runs an algorithm to show you where the patient is functioning. And anything in red, I explain to my patients, anything is red is something that will be worn away or chipped away with time. So when someone sees red on their lower anterior teeth, you know that's prone to fracture and prone to chipping, okay? So this is his pre-treatment occlusion. Please note all the red. And this is his post-treatment occlusion. Everything is very, very more linear, more smoothed out. And we needed a small amount of bite adjustment in the red areas, but he was perfect after that. Okay. Let's talk about periodontal health for a minute. I always say there is nobility in keeping crooked teeth clean. And I applaud all my patients for keeping up their recare visits or their perio visits. But I always say, you know what? There's no way out of the game without straightening your teeth. There's no way out of the game without straightening your teeth. And if you want evidence of that, check your patients after they skip a prophy. Because what happens when somebody skips a prophy? More inflammation, more plaque, tartar, more bleeding on probing. Probing depths increase. Gingival architectures continues to change. And your patient can never achieve that level of health that they once had once they're on a maintenance program and they skip a prophy. The 5s that you work so hard for slip to a 6, or the 4s that you maintain slip to a 5 or a 6, and it's really hard to get back to a 4. Okay. And I call this, obviously the Karen patient. I'd like to talk to the manager, because how many times do we have a patient that says, of course I'm bleeding. She poked me too hard. Nobody likes that. Okay. She scraped too hard. She poked too hard. The hygienist made me bleed. She's got that pokey thing all over my mouth. On and on and on. Okay. One of these sets of teeth is hard to keep clean. One of these sets of teeth is easy to keep clean. A new day, a new rule. When you see tooth malpositions, when you see tooth rotations, when you see malocclusion like this, your treatment plan has to include this. And I'm not saying it needs to be done right away. It needs to be diagnosed, treatment planned, and prioritized. That means put it in order. It could come first, it could come second, it could come last, but it needs to be diagnosed and prioritized. Benefits are that a proper occlusion solves a lot of problems, okay? Establish proper overjet and overbite pre-prosthetically. And how about those chips that we keep bonding and rebonding, okay? And our patients come back and put the blame on you. Here's a case of worn anterior dentition. Maxillary anterior teeth chipped and worn. Here's her plan. All we did was expand. We only expanded. I did not IPR the lower. I did not retract any of the lower teeth. I just expanded the upper teeth. Here she is on the bottom is after bonded, protected occlusion, proper overjet and overbite. Extremely simple case. Extremely simple case. Okay. Establish overjet and overbite for veneers. Now, we cannot place veneers over top of these teeth, okay? Despite what we think we can change in the actual inclination of the teeth by bonding veneers on, we know that we can't do this, because unless we are changing the axial inclination of the root, the problem will show up in the veneers. That means chipping, cracking, wear, recession, possible abfraction in the posterior regions, okay? Here's her pre-aligner photographs. Here's her established overjet and overbite. Here's her wax up, and we recently went to completion on her, okay? 3 veneers, once again, different case, okay? I only did Invisalign on the lower arch because the lower arch had malpositioned teeth. And I want to show you this up close, okay? I put arrows here to show you these teeth here. If you follow proper veneer theory from the early 2000s, what I learned was that if you want to correct the malposition in these lower anterior teeth, if you want to correct this in veneers, first you need to take a drill with a burr and you need to prep this back into line. You need to prep this back into alignment. You need to get down to a place where the incisal edges are all in a straight line first. Then you reduce 2 millimeters for your porcelain. If we were to follow that rule on this case, we would end up with at least 2 root canals, okay, minimum, okay? Now we can cheat, we can certainly cheat. In fact, we used to look for cases like this. This was an indication for veneers not so long ago. We used to look for this, but the problem is if you veneer these teeth, you're going to compromise your prosthetics. You're going to compromise possibly aesthetically. You're going to compromise possibly strength. You're going to compromise something unless you give the veneer proper thickness. And you cannot give this veneer proper thickness without going into the pulp chamber. So therefore, we established straight line. Okay. And then I was properly able to prep her teeth for upper and lower veneers. Okay. Here's a case that I saw recently. Why am I getting a space between my veneers? Here she is up close. Now let's backtrack this here. Veneers done August 13th, 2014, 9 years ago, going on 9 years ago. Has not been to my office, not once, since veneers were placed. And shows up and wants to know in the summer of 21 why her veneers were splitting. Well, I said, let's take an iTero scan and turn on the occlusal function and take a look. Here's her occlusogram. Occlusogram, again, an algorithm that runs on the iTero machine to show you hot spots in the occlusion, spots that are a little bit too tight. Well, look at, she's all red on the incisal edges towards the buccal, and she's all red on the lingual of the upper anterior. So she's moving these teeth orthodontically due to too much pressure and not enough overjet. My instructions to her were clear. You need clear aligners. Nope, I'm good. Thank you. Walks out of my office. Fast forward 5 months, here comes these text messages from a number that I don't recognize. Hi, Dr. DiRezze, sorry it's late. I'm going to send you this text because I broke things now. And I have a client meeting tomorrow, of course, of all things. She has a client meeting. So of course I bend and I say, who is this? And of course, I'll see you in the office in the morning and I'll patch you up like a good doctor that I am. But the next day I said, I'm going to patch you up, but you know what? You really need clear aligners. She says, okay, I'll do it. And when I asked her, well, why didn't you do it 5-6 months ago when I said it? She says, I didn't know if I want to go to Smile Direct Club or not. To which case I stopped thinking about her in terms that I was previously, getting upset that she wasn't following my advice. And I started to understand, well, she's a consumer and she had a lot of options. And I really didn't give her the time to discuss with me because I fit her in the schedule. I was super busy, super packed like every day. And I didn't have time to consult with her about Smile Direct. So I did. And I alleviated her concerns very quickly. And she decided to do Invisalign with me. So that was a win, but it was a real big lesson to me, not to take things for granted, not to take your patients for granted, and to realize that in this day and age, this is a consumable product. And yes, we are doctors. Yes, we have loyalty from our patients, but we're also selling a commodity that we need to be aware of. Okay. Real quick, here's her plan. Point to IPR across the bottom, scooch back, scooch back, scooch back, and establish a proper overjet and overbite. The icing on the cake for me was when this number came in and she was not done Invisalign yet, but she cracked the veneer. And this was while I was teaching for Brock in Chicago, session 2. So it says right here, sorry, I know you're in Chicago, but I don't know what I should do at this point. So luckily she had a nice template because she had the trays. I was able to make her a temporary right quick and get her out of trouble. The cornerstone or the pillar or the foundation of a general office should be better health, better function, and better living for every one of your patients, okay? When you see this message, when you believe this message, something clicks and you can't unsee what you've seen. And I present to you something I put into every single lecture, my light bulb moment, my light bulb patient. Here she is. Wonderful patient of mine in my office, by far my most photogenic patient. And to say that she cares about her front teeth would be an understatement. I'm not saying anybody out there doesn't care about their front teeth, but she really cares about her appearance and what she looks like, okay? So she presents to me with this root canal thing here, and I call it root canal thing because I'm not even sure how to diagnose this as a general test. I don't know if this is a post with sealer coming out. I don't know if this is gutta percha. It's kind of bent. It could be one of those fiber posts. I'm really not sure what this is. I just know that it looks like it's been retreated just because of the massive canal space it takes up. But eventually that fractured and it was replaced by an implant, and it was lovingly replaced with this crown that I did several times over again for her until I got it right. In fact, I did it so many times. I took pictures in different lights and different settings on my camera to show exactly what a phenomenal job I've done for her. Because if you were to see the text messages going back from her phone to mine about how frustrated she was about getting a decent final product, anybody would do anything to circumvent and to go back in time to fix things for this young lady. Okay, there it is close up. Now, the problem is, despite the fact that gingival architecture is good, you see a pale pink stippled appearance. You know that it has some gray metal underneath, and she's not happy with that, but there's nothing I can do about that. The crown is phenomenal. Here we are, fast forward, we enter the world where we scan all of our patients in hygiene, and we pick the ones that seem like they might be a slight bit interested in Invisalign, and we run a ClinCheck for them. So I ran a ClinCheck for this young lady, and I showed her pre-treatment malocclusion, and I turned on the occlusal function, and there it was, staring right at me. If anyone can see this, there's a green spot on the back of this veneer crown, the back of this implant crown that I've done. But take a look at this here on the lower, on the mandibular arch and lower anterior. Solid, bright green dot, occlusal spot, occlusal high spot before treatment. Now, if any doctors like me, and I'm a thinker, so I know a lot of people think this. Now I see where here, where here, where here, where here. I think, all right, group function, we're pretty safe. She might wear away a little bit, but she's not going to break anything. So that's why my alarm bells didn't go out. But once I saw this, I'm like, oh my God, did this pre-treatment malocclusion have something to do with her fracturing that root? And it probably did. And I didn't foresee that. I don't know if anybody could foresee that. I know she had the risk factor of the retreated root canal that took up a gigantic amount of canal space. I know she had that risk factor. But what if this was the last straw? Okay. I didn't know, like when I thought group function, I thought everything slid perfectly. I didn't know that you can have like a clunk first and then a smooth glide into group function. That wasn't even on the radar for me. So that was an education for me. But what if we presented clear aligner treatment years ago before she ever broke the tooth? Would we be accused of overtreatment? If she had adequate overjet and overbite, could we equilibrate this into occlusion? She had no abfraction lesions. What is the risk to benefit ratio? And would other practitioners call us crazy for wanting to charge this young lady money in order to fix a problem that was just so slight? But knowing now what I know now, I wouldn't trade it for the world to be able to offer her Invisalign before, because I would do anything to circumvent fracturing that root. The importance is this here. Once you see this in your office, that has to equal in magnitude when you see this in your office. I'm not saying one has to be done before the other one. I'm saying that these both need to be diagnosed, they both need to be treatment planned appropriately, and they both need to have a priority in the treatment plan sequence, because even though this is an imminent emergency, this at some point could turn into an emergency. It should not be treated with any less severity as this. Okay. Here's a good point to stop and reflect on 20 life hacks that can help you at work. And let me read this here to you. It says, I've learned that most people aren't really that smart despite education and job titles. They are just really smart about one thing. I learned this a long time ago, but when I was young, I generally believed if somebody had a fancy degree, they were smart in general. This is definitely not the case. And I'll just leave that right there for you to ponder. I won't make any generalities about what job we do or what colleagues we have for a living, but we are dentists, and that's all I'm going to say. The next few slides, we're going to focus on the heart and soul of a clear aligner culture. We'll talk about goals for treatment, case selection criteria, how to solve crowding problems and create space, what moves do we use, and what are the two things, the mantra, what do we need to move teeth and plastic, okay? This slide got a sequence, so as I click through, here we go. Goals for clear aligner treatment, AKA how does this fit into my office? Well, first and foremost, address the patient's chief complaint first. Use predictable movements. We want to do expansion and IPR versus molar movements and rotations, okay? We want to be fast, 6 to 7 months tops, possibly 20 trays in and out is a good rule of thumb. No posterior open bite, that kills the game, and minimum number of refinements or mid-course corrections. Stay in your lane. Case selection means no growing class 2s, no growing class 3s. We have orthodontists for this. No more than 50% bone loss on your lower anterior teeth. No reverse overjets, and no bilateral crossbites. All these are no-go territory. We cannot do this predictably at clear aligner world unless you have a lot of experience. You need to have a deep toolbox to bail yourself out of problems if they occur, and not to be tackled when you want to fit this into your office at a high rate, at a high magnitude and a high rate of speed. Okay. Why do we follow these rules? Well, we want predictable treatments, we want repeatable treatments, and we want to implement this successfully into a GP practice. We don't just want to do 3 cases for the year and be done, but we want to do this predictable. We want to rubber stamp this as much as we can, okay? And we want to minimize refinements. Here's a case in point, young lady that I did recently. This was more of a complex case because she was growing, but here's her before and here's her after. Way different young lady, okay? And here's how she expressed herself. She has this unique style about her when she comes in, and she certainly is not a little kid anymore, okay? And we started strong. She was motivated. She was a little girl. She was compliant. And this is directly from the notes. Patients wearing the trays. Her iTero scan and progress scan was green and going according to plan. Patient was using her munchie, which is an acceleration device. Oral hygiene was good. Patient motivated, good patient. Then as treatment went on, we entered the gray area where the notes started to slip and say stuff like this. Well, all the teeth are green except for tooth number 10 and tooth number 12 are yellow. So those 2 aren't moving. We advised she got to use the munchies more. We stressed oral hygiene because she wasn't as clean as she used to be. Patient needs to be more compliant because she admitted to not wearing the trays as much. And then as a little bit more time went on, the wheels fell off. Patient lost tray 24. Patient not wearing anything on the bottom. Patient not using her munchie. Several gray areas on the scan. Patient did not bring trays to appointment. That's a big red flag. Patient stated she did not brush her teeth today. Patient should be in tray 8 patient is in tray 8 when she should be in 7. Mom threw 7 away. Patient only wore 6 for 2 days. Attachment tray did not fit anymore. Refinement trays did not fit. The wheels completely fell off. The problem is I am addicted to seeing a change in the patient, going from here to here, that I keep looking for these cases and I keep jumping into these cases when I can, okay? Things like this, although there are some problems, they're highly satisfying, okay? Here's a good friend of mine, Gina Marcus from Miami. I happened to share with her the before and after pictures, and here's her comment to me. This is gold. This is amazing. Purple heart, purple heart, purple heart, purple heart. Love this for her and love this for you. A dental high five, if you will. So the infectious culture of clear aligner culture is something that I'm addicted to. And the camaraderie that we have with our colleagues when we do a great job for our patients is second to none, okay? How to solve crowding and how to create space. Well, we got 4 ways, of which we should only use 2. Expansion and IPR is preferred over distalization mechanics and extractions, okay? Here's a case here that I illustrate the relationship between expansion and IPR, the interplay between the 2. So to solve this crowding, my ClinCheck calls for 0.5 IPR, what I call wall-to-wall, distal of canine to distal of canine, because my parameters state not to add any more. So this is considered wall-to-wall. The maximum IPR I could ever do is in this ClinCheck right here. But to show you how to minimize IPR, what I've done is I've used my 3D controls and I have done something that I call obnoxiously expand the premolars. Now, we can never do this clinically. This can never happen clinically, but I want to show you the more you expand, the less IPR you need. So from where I went from 0.5 wall to wall, I've got this down to 0.2, 0.5, 0.2, but I've expanded the premolar. See, so when you want to get away from IPR, you can use expansion as a tool within proper limits, okay? Let's take a look at this next case here. I went back to normal, and instead of expanding the premolars, I've expanded the molars. Again, this cannot happen clinically, but I want to show you as a representation here. When you expand molars, you don't get as much resolution of IPR, okay? Because you only gain arch space by expanding the premolars and not the molars, okay? Here's our moves here. 3 moves: tip, torque, and translation, or other, stated differently. Tipping, yes. Clear aligners can tip anything at any time very quickly. Torque moves, not so much, okay? Translation, yes and no. Yes in the anterior, no in the posterior, okay? And two things that we need to move teeth in plastic: surface area and anchorage. How to tell if a treatment plan is good: anchorage and overjet. Attachments real quick that we need to go very quickly through. We use attachments for direct force, we use attachments for support, and we use attachments for anchorage. Purpose of attachments: to put pressure on a tooth to make it move when you want a more directed force. I can't give any more words to this picture other than you can move a piece of granite with your hands if you wanted to, but if you had this thing called the carry clamp, it would make your work a lot easier and more efficient. And that's the purpose. That's one of the purpose of attachments. Optimized rotation raindrop attachment here on the canine looks like the fan blade of a windmill or something. So I always think, well, when I see this thing, it looks like it catches the wind and will like spin that tooth. So that's a rotation attachment. So when you need to rotate a canine or when you need to rotate a tooth, you often see a raindrop rotation attachment called a G3 on a canine. Here's another type of attachment. It's called the skate ramp because it looks like a skate ramp, okay? This is used to extrude a tooth. You see the arrow giving the vector of force or the direction of force. When the trays slip in, it puts a vector of force on any part of this ramp and it extrudes that tooth very predictably, okay? This is a double spike attachment. I call it like a shimmy shake attachment because you see that the force goes on the flats and this tooth will kind of wobble or teeter its way into position. It's a translation. It's a translation attachment, okay? Here they both are here clinically, or rather diagrammatically on a clin check, okay? And we also have support attachments. Support attachments are like the smiley faces, they're the half circle frowny faces. Their purpose is to make sure trays do not slide off during intrusion. Now let's take a look at this here. Support attachment, half circle upside down. The tray wants to push these teeth in, but the tray has a propensity to lift up because Newton's third law. So this attachment is placed here on the lower lateral incisor, kind of just to keep the tray from lifting off the tooth. Here's support attachments here. When you want to intrude central incisors, you need support attachments next door so that the tray doesn't slip off. Okay, here they are diagrammatically. And these again are support attachments to help solve a deep bite. So diagrammatically, when you have a deep bite here, you're intruding here, we're putting these support attachments here to make sure the trays don't slip off. So generally 3 types of attachments. Here's a deep bite case that I solved using optimized deep bite attachments. That's pretty good resolution in plastic for this deep bite, okay? Purpose of attachments: anchorage. We want to anchor the teeth. Teeth that are not moving need to provide resistance to teeth that are moving, okay? And when we hear this blanket statement, like clear aligners don't work or Invisalign doesn't work or such and such doesn't work, I'm going to show you one of the only reasons why it doesn't work is represented right here. We all know what's going to happen here, okay? Pulls the trigger and it doesn't go where it's supposed to go because he's not anchored. Boom. Okay. If there's one attachment that you remember today, the only thing you need to remember today regarding attachments is this here: horizontal, rectangular, beveled attachment for anchorage. Looks like this here. Looks like 2 premolars with 2 squares on them. That's it. Those 2 squares, Dr. Galler calls it secret sauce to every case. Okay. Provides anchorage and provides a positive seat that helps your patients track. Your patients can hear a click over those large attachments. They know that their trays are seated. And most importantly for anchorage, you're going to be doing something in the front here. You know, there's an attachment here. So something's going on in the front, but you need the stability here so that when this action starts moving here, your trays are braced over here. That's anchorage. This can be defined in your parameters on your software, whatever software you're running. Just tell them to add horizontal, rectangular, beveled attachments in your premolar areas, and they'll come with that all the time. This case has good anchorage. This case has poor anchorage because if these are premolars, where can your trays lock in? Your trays can go on this flat on this side, but on the smooth, curvy surface, you cannot exert any pressure. You cannot provide any resistance to force happening on this windmill on this raindrop attachment. You cannot negate a reciprocal force here. So this is bad anchorage when you see something like this on a premolar. Okay. The magic of the horizontal bevel. Trays lock in the long flat surfaces, the right angles, and they're engaged. They snap in, and they're the preferred attachment for anchorage. Okay. Here's a case here that I want to show. Detroit's favorite implant rep. She's very popular amongst all the implant offices in Detroit. Here's the age of scanning everybody in hygiene. She wants me to do her Invisalign for her. So she presents with an anterior open bite. Here's her plan. Doesn't matter what all these say, but I'm going to point this out. Anchorage, 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 anchorage. Whatever else you need to do here, you can do whatever you like because the case is properly anchored. We learned about the extrusion attachment, the skateboard attachments here. We learned about the shinny shake attachments here that are going to shuffle these canines where they need to go. Okay. Here's before and here's after. It is technically good. It's not great. Okay. This is open here. This is a little bit more closed. This is open in the beginning, a little bit more closed. But I want to ask you guys a question. Why do you think I didn't get to completion on this case? What is it about this case? What does this case need to go to completion? And since I can't take your comments, this is not a classroom. I'm gonna tell you, this case needs IPR on the bottom. So we need to smooth, slenderize, smooth. And we need to scooch the lower anterior teeth back just a touch. And we need to give enough room to extrude the maxillary anterior teeth. So we don't have room to extrude because she's touching here. However, this young lady wouldn't let me touch teeth to do IPR because she's a dental rep and she knows what's good for her teeth. She definitely does not want them IPR'd. Dr. Rondeau puts a whole article on air rotor stripping from the 70s or 80s in his course manuals to teach you how safe it is and how predictable it is. And I suggest that everybody read a copy of that in order to properly present IPR to their patients. Okay. Here's an anterior open bite case that I did. This gentleman in my office, I've seen him eat and I've seen him socially. And I insisted that he do clear aligner therapy with me. He is single, and I'm not sure if he's a little bit socially awkward. And I think that the malocclusion, the bite, the inability to chew properly, the infantile swallowing, that I'm pretty sure that all that plays a role in how he does socially. So I was pretty insistent that I help him out and do clear aligners. These are his befores. Here's his attachment plan. Anchorage on the back, extrusion attachments in the front, and you can do whatever you want. He's well on his way to being closed. This is at our last visit. I closed him down. Needs a ton more IPR and a ton more extrusion, in order to get him closed. Okay. Here's his scan. His green means everything's going according to plan. Okay. In Vegas, dealers learn the cards by studying the patterns. They don't count. They don't go 10 plus 7. They don't go 10, 6, and 5 is 21. They don't count up. They watch the patterns. Similarly, you're going to be able to recognize the patterns in your clin checks. For example, is this case anchored properly? Take a split second to look. No, based on what I told you. Are these two cases anchored properly? Takes a split second. No. Is this anchored properly? Yes. We got squares all over the place. These trays are not dislodging, and this is going to provide adequate resistance to do whatever you want in the anterior. Is this anchored properly? No, it's missing a tooth. You need to either go forward or go back a tooth for anchorage. Is this anchored properly? No, too much motion in these teeth here in order to properly anchor. Is this anchored properly? No. Is this anchored properly? Yes, and yes, and yes, and yes. So tomorrow when you go back to the office, open up any active clin checks you have, open up any other cases you've got going on, and I urge you, please take a look at your attachment plan and recognize, are you anchored properly, yes or no? Overjet, you need 1.5 millimeters, and that's a rule. We aim to get decoupled anterior teeth. Decoupled anterior teeth means they cannot touch at rest. I've looked up the thickness of Invisalign retainers. They are approximately 0.7. So we do 0.7 plus 0.7 gives you roughly 1.5. There's my Jethro my Jethro picture here about ciphering. Okay. This looks pretty good, but from up above, we need more. We look at our overjet table here in any software. 1.4 is not enough. We need another 0.1 millimeters. So we add that via IPR. Okay. Again, 1.4. Here's software here, 1.9. Well, that's more than 1.5. So we have adequate overjet. Okay. The rule of thumb, make sure you see space, use the measurement feature. I always say you should be okay. And what could go wrong? Well, we know that there's a lot of things that can go wrong when things are not done properly. Why does 1.5 millimeters over, like, why is that the magic number? Well, you're never going to have as much overjet as you have planned. You're never going to have 100% expression of the trays. So when you take the trays out, your vertical is going to close and your teeth will bump into each other if you don't have at least 1.5 millimeters of overjet. Okay. We need the clearance because lack of overjet equals an anterior interference, and you will get a posterior open bite. Okay. Tools to gain overjet, we have proclination and IPR. Okay. And mandibular intrusion to a certain extent. I stated already what can go wrong. Well, posterior open bites can go wrong. That's the main thing of the game. When you have a posterior open bite, that is an extremely difficult thing to get back from. So why did this happen here? Okay. Where's the problem? The problem is right here that he has an interference. And what can help us find this? An occlusal tool. Any software will have an occlusal function. You turn on the occlusal tool and you see this interference. And interestingly, look at the anatomy that he has. That abnormal accentuated marginal ridge anatomy was the cause of this. So he had a variant of normal anatomy that caused this posterior open bite. Here's a case here that I did. She is end to end on this tooth here, a little bit closer. Here's my attachment plan. Main thing to remember, I'm properly attached here. I'm properly anchored. I can do whatever I want in the anterior. I am properly anchored in the posterior. However, this case here had no IPR and not enough overjet. So we had to go into refinement, and I had to add 0.4 IPR in all spots. And here's our finished product. There's the finish. Once again, I always say happy, happier. And again, this is what I can't get enough of, pictures like this. And I'm so amazed that she came in on day one knowing that she was going to get pictures. She knew she was going to get pictures taken. And this was her hair. However, the day that we took the attachments off, people don't know if they're done. People don't know if they want to go into refinement. People don't know if they're going to get more trays. On the last day, she didn't know she was going to get her attachments off. She didn't know she was going to have pictures. Yet this is what she looked like on the last day. The change in people is addictive. The change in people is amazing to me. And that's why I keep coming back. Here's a technically great case here that I did. Let's take a look at her problems here. She has end-to-end bite. She has open bite here and tiny bit of maxillary crowding, but a lot of mandibular crowding. Okay. Overjet is non-existent. So we put our treatment plan considerations down. We have to solve the crowding. We have to solve the end-to-end bite. We have to solve the open bite. Here's my anchorage plan. Once again, I'm anchored properly in the posterior. I'm anchored properly in the posterior. I can do whatever I want in the anterior because I'm anchored in the posterior. Here we go. Extrusion, 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 extrusion. So we're heavily depending on IPR to scooch the lower teeth back, giving enough clearance to extrude those teeth to give proper overjet and overbite. Let's look and see how it worked out. Here's before and after. Here's before, here's after. Here's before and here's after. Solve the upper crowding, solve the lower crowding. And again, I say happy and happier, okay? A technically excellent case. Not too difficult, but just attention to detail is everything in clear aligner world. I've been in the game for 20 years, and I like to say I've seen some stuff. I've seen this. I've seen barnacles on teeth. I've seen, this is tartar and calx that I've extracted. This almost looks like, used to look like an orthodontic appliance to me, but it's a tartar bridge. Okay. And I seen this by far something that I couldn't prepare for. This picture was taken in 2003, before you ever seen Grills or Nelly or any of these people with the bling in their teeth. Before any of that, this patient came to me and said, "Doc, I want you to put this bracelet inside my teeth for me." And I kindly said, "I can do that, but it's going to cost $32,000. And he said, "I'll get right back with you." And he promptly left my office. So I dodged a bullet there. So where do our cases come from? Hygiene. We're going to talk about hygiene. We're going to talk about the dental health scan and talk about the funnel. Okay. I've only got a few minutes left, so we're going to go through this here. This is the iTero scanner. This is my hygienist, and this is the funnel. Okay. Dental health scan. I call this putting us back in the driver's seat. I call this putting the ball back in our court. I call this putting us back in control. Okay. These are hygienists doing a health scan. And I have a question for doctors out there. Why do you think surgeons do 300 or plus implants a year? Why do you think orthodontists do 300 or more cases a year in ortho? And I don't. Okay. The answer is scan every patient and watch your numbers rise. Okay. We can make a splash in our office. We have a numbers advantage in hygiene that specialists don't. We can take advantage of that by scanning everybody. Seeing is believing. And this company right here, Keystone Dental Implants, has hired me to discuss scanning and hygiene because Keystone wants to be a player in the GP implant game. So they thought that by scanning every patient and diagnosing edentulous areas would lead to their company selling more implants. So they've hired me to have a talk about getting iTero scanners and scanning and hygiene to make a difference for their company. So this is not just clear aligner world. This works if you want to do a lot of bite guards. This works if you want to do a lot of veneers. This works if you want to do a lot of class 5 fillings. Whatever you want to do a lot of, purchase an iTero, and seeing is believing. Elements of the dental health scan: recession and abfraction, malocclusion, caries and wear, broken restorations, probable caries, perio, disseminated occlusions, all things that your patients can see. Outcome assessments, occlusogram views. What we do is we turn on the occlusogram view, but we don't show the patient yet. And we tell them, listen, we're going to look for red spots on your teeth. And if we see any red spots on the occlusogram, those are areas of heavy wear that are going to chip and wear away. And then boom, we turn it on and we show them. And then we start to formulate a plan on what we can do to fix that. Whether they're interested, or if they're not, we put it on the back burner for 6 months until we meet again. But this will get their attention by showing them red spots on their occlusion. Okay. Again, occlusogram view, it's an algorithm that shows the force of the bite. There is no paper that goes in between. There's nothing to hook up. There's no accessory instruments you need to buy. It is an algorithm that number crunches wear facets and tells you how strong you're biting. And it is scary how accurate it is. I always ask if any team members have had an iTero scan, if they turn on the occlusogram view, how accurate is it? And I always get 3 or 4 people that like, yep, it's really, really accurate. Okay. And it's a powerful presentation tool because you tell them what's red will be worn away or chipped away. This is an Invisalign Outcome Simulator Pro assessment. This is fresh from today, May 9th, 2:30 p.m., my office. This brand new Invisalign consultation comes in and he's worried about the spacing in between his front teeth. And I said, let me show you what can be done. And we turned on this occlusogram view and hooked. He's accepted treatment. We're going to run the ClinCheck rooms and we're going to order the trace for him because of this view, because of the simulator. Okay. Dental health scan, seeing is believing, diagnose, treatment plan. And I always say prioritize, put it in proper, itemize it properly. Okay. Scan every patient that has an exam, every patient that has a comprehensive exam, limited exam, periodic exam, any exam. Okay. And find a method that works for you in your office. Okay. The AACA says that most people have either 1, 2, or 3 scanners in their offices out of 3,400 members. Okay. Some of them have 4, but when we get up to 4, we're talking about doctors with multiple offices that are run under the same account. So the numbers get kind of skewed after 3. What is the ideal scanner number? 1 for every hygienist, 1 for every clear aligner room, 1 for every doctor. So I need 4, but I've only got 3, but I'm not suffering because of it. Okay. What is your number? Only you can answer that. It's something that you need to find out from your team. Okay. But I'll tell you what, I tell all my doctors, if you think that saving on in your impression material is going to pay for your scanner, you're not in the game for the right reasons. That is never going to happen. Okay. So if you're waiting for that day to come, it's never going to come. Okay. Staff roles, my dental assistants, Adriana and Rachel. I say their importance cannot be understated because they have to stop what they're doing whenever you need a scan, because everybody else will make themselves look busy, but your dental assistants always save the day for you. So I say scan on a dime, and that's what they do. Okay. Hygiene, scan and educate. Okay. Of course, hygienists being hygienists, what's in it for me? So you need to have this discussion with them about being fair with them, about incentivizing them, about giving them adequate time. My office, I say, can you scan when you're not taking x-rays? And that's transformed into, doc, you should get us a hygiene assistant, which I've done, but everybody's getting scanned. Okay. So it's worth it for me. Office manager, financial coordinator. This is Penny. Benefits is the number one thing she can do for you and your patients, because if you do not have a breakdown of benefits, if there is a patient that has insurance, trust me, they are not going to take your word for it that insurance does not cover Invisalign. They want to see it in writing, and there's going to be 0% Invisalign done that day unless your office manager has a printout of their benefits and can tell them unequivocally, you do have coverage or you do not have coverage, because people will not take your word for it. Post-COVID, people will not take your word for it. Seeing is believing. So the most important thing about this young lady here is that she gets everyone's breakdown of benefits before the day begins and lets me know this patient has orthodontic coverage. So if you want to discuss something with them in hygiene, feel free, because they've got $2,000 coverage, or whatever that number is. Real quick, teamwork. On December 15th of last year, I had 34 cases and we need 65 to reach platinum. I was resigned not to make platinum. I thought that ship had sailed. I was second guessing my systems. I was a little bit upset, but my team took it as a challenge and they all pitched in and they said, well, the office manager said, I'm going to circle back with the people that we've done consults with, and I'm going to run a coupon. And the hygienist said, yeah, we'll scan everybody in hygiene. And the assistant said, well, we'll scan whoever you can't scan. Everybody chipped in and we closed 31 cases in 2 weeks. So it can, some of them were a recall activity, a reactivation activity, but you cannot understate the teamwork that is involved in the clear aligner culture. Okay. They made it happen for me and I'm forever grateful. Okay. Everybody has a job for the funnel. The funnel has a defined role for everybody. The hygienist and the dental assistant scan, the hygienist educate, the doctor confirms the diagnosis, financial person makes it rain. I mean, gets the financial things in order to start cases. This is what the funnel looks like. How many patients are coming in today? How many patients have you scanned today? How many hygiene educations conversations have you had with people that can clearly benefit from Invisalign? How many treatment plans have you presented? How many financial plans have you presented with insurance breakdowns? And how many cases have you started? And this is lather, rinse, repeat every single day. Every single day this needs to be filled out and it needs to be reconciled. Like, why didn't you scan this patient? Why didn't you scan that patient? That's the only way you're going to start cases. Okay. When you get busy, scanning is the last thing. The first thing that goes bye-bye. Your team members will forget to scan because they are too busy. But the funnel works when it's implemented properly, but it requires constant attention and constant motivation. Delivery of care, we need to talk about attachments. Attachments, simply stated, when you squeeze composite from a gun into an attachment template, a lot of things can go wrong. You can distort, you can deform, you can have crazy shapes, you can kill yourself with excess, and you can put the attachments in the wrong spot. I've solved my problems by using this Tetric Evo Flow. Okay, it handles well, it takes the shape of the template, and there is no problems with placement. The most important attachment tip of tonight is, number one, press the tip all the way into the well and extrude the composite as you back out. Number 2, place the tray inside the patient's mouth and have them bite down to ensure proper seating on the tray. Number 3, push a flat tipped curing light into the attachment template and make sure that attachment is perfectly seated on the tooth in order for it to be active during Invisalign treatment. Okay. Isolation is the key. Do not get anything contaminated with saliva. And here is something that I put in here because I want to show you that my Invisalign knocked off a crown one time, but if you look closely, this crown still has the attachment placed. And for most of you, everyone asks me at courses, how do you bond to crowns? Because it's so unpredictable. The answer is I've never done it, so I don't know. But my assistant does it every day, and she has no problems using this material right here. Reliance Orthodontic Products out of Chicago. Okay. Number 2, Dr. Blocker blacklight technique. Excessive flash will inhibit tooth movement. So when you see flash, you need to get it off. This is Dr. Christina Blocker with the black light, and she invented this technique. Everybody should follow her on Instagram. This is what flash looks like. A tray cannot be properly seated on this tooth when there's too much flash. And this is what it looks like. This is with the flash. This is cleaned up. Okay. 2 things needed to move teeth in: plastic surface area and anchorage, and excessive flash negates your surface area. This is a quick video of using the blacklight technique, and this is someone using one of those carbide finishing egg-shaped burrs really carefully around the attachment in order to clean the flash. Okay. IPR by far is my favorite section of the class. So to review: extraction, no good; expansion, very good; distalization is a no-go; IPR is a positive. So adult Invisalign treatment is highly dependent on IPR. Okay. Expansion alone cannot solve all your spacing problems. Okay. And IPR is predictable. IPR, how do you IPR? Do you use a disc? Do you use a mosquito burr? Do you use a mosquito burr sideways? Do you use a diamond string? Everyone's got their method. But one thing for sure, IPR lends itself to a lot of problems. First and foremost, take a look at this ledging that happened here with a disc. Disc went in, disc created space, but it went right into the junction here and caused ledging. Okay. This is an IPR case on a straight wire case. Sorry for the grainy picture. Dr. Louis Coury from Quick Strips, the inventor of Quick Strips, keeps this picture in a frame, keeps it on his table display when he does the dental shows. A lot of you have met Louis, or a lot of you have known Louis. Don't be afraid to go up and look for these pictures. He always keeps them on hand, and he can talk to you at length about IPR. Here's something disgusting. This is an accident that can result from improper disc usage. And I always get the biggest gasp in my classes when I show this. Okay. This gentleman here is an iTero rep, but he had the misfortune for working for another company before iTero, and he got into another clear aligner, and that software called for 0.5 IPR right in between the central incisors. And that's unfortunate because he could have had 0.2 all the way across the front and created the same amount of space. Now it's up to me doing his Invisalign to fix this, and I'm just not sure how to recreate this interproximal contour. I'm probably going to have to end up bonding. Okay. But when I see this, I cringe, because look at the disc is not concentric. There's a high speed wobble. We don't know what kind of IPR we're getting. We're hitting the papilla, the lower incisors in the way, and the tongue is in the way. This is just screams disaster all over it. Okay. Here's something that I would not want to have done to me. We talked a little bit before the webinar about doing straight IPR in the posterior, and I'm still not a fan of straight IPR in the posterior with a saw or with a disc, because this can happen. And this can happen. Now, I'm going to show you the radiographs. The problem here is that these spaces are radiographically closed. These teeth cannot go back any further. This is the case that was that happened to a colleague of mine that was transferred to this colleague. And this patient's been in refinement for 3 years. Doctor wonders why he can't close the spaces. Okay. Upon seeing the radiographs, this is why. This is the contact here. Whoops. Sorry, I advanced that side. This is a contact here, but this is open here. This is a contact here, but this is open occlusally. This is improper IPR. This is closed. These teeth cannot go together anymore. But look how open this is at occlusal. Nothing can help this except for crowns for the most part. Okay. My IPR wish list, no hand pieces, accuracy, predictability, safe, no ledging, and no destroying embrasure spaces. Keep tooth contours. Alas, we have the quick strips. Okay, quick strips comes in a clinic pack that you can accurately measure your IPR, and we do sequential IPR to avoid wedging and to avoid collapsing the spherical particles on top of one another and getting fake IPR. I want you to look at the contours of these lower incisors. Can everybody see how the contour, the shape is still the same? These aren't toothpick. Look at the incisal edges, the angle here. It's not hacked up. It's not like a toothpick. Look at this posterior IPR. Look at the contour, how it's curved. Quick strips, and Dr. Louis Corey made curved quick strips so that you can keep the original contours of the teeth when doing IPR. And I think it's brilliant. Okay. Compare this IPR, compare what this looks like to this, or this, or this. Okay. I think we have an obligation to our patients to give them as much as we can, something that looks like the first picture. Okay. And I say you can't reinvent the wheel when you do IPR. I want to show you guys this case briefly, where there was 4 treatment plans, 4 revisions. Not one of these include any IPR. It's obvious that these teeth need to be IPR'd if you want to have any chance of a proper overjet and overbite. Okay. More than likely, it's an extraction case or a surgical case, whatever, what have you, depending on the patient's age. 4 refinements, 10 treatment plans, no IPR anywhere. Okay. The problem is this patient was a doctor, a friend of mine. The real problem is here's one of his cases for real. This is one of his cases. Now here's treatment plans 1 and 2. They both call for IPR. Okay. He writes back to get the IPR removed because he's a doctor. He doesn't believe in IPR. He wants to save the enamel. So he says that he doesn't want any IPR. In fact, here's his instructions. Please extrude maxillary laterals to close the spaces, and down here, no IPR, please. Okay. Problem is this can't work. So treatment plan number 4 comes back. No IPR. There's no IPR to be had. The changes between 3 and 4 are negligible. I play this like there's like a little toggle going back and forth between the gums just to show you. The teeth did not change. There's physically no change that can take place to fix these teeth without IPR. Okay. So this guy transferred the case to me. The first thing I did was add wall-to-wall IPR. And there was my treatment plan. I'm not going to play it through because we're short on time. But here is the beginning where I started, and then here's the end. Nothing earth-shattering, no rocket science. We need to make room. We needed room to properly restore adequate overjet and overbite, and to extrude the lateral incisors to appropriately close the open bite that he had going on, and to correct the crossbite that he had. Okay. Monitoring techniques, you want to see the fit of the trays. You want to compare the clin checks. You want to identify problem tracking. I use an iTero scanner in order to properly see the colors. Top monitoring techniques, compliance. If your patient misses appointments, if they're not interested in coming, if there's no aligners in their purse, if they fumble when they put on the aligners, they can't tell top from bottom, all these things mean they're not wearing their trays. When you see something like this, that means they are wearing their trays. When you see coffee stains, when you see tartar, calculus, that is a compliant patient, okay? Unfortunately, we have a bad message from Smile Direct Club that says we now have aligners that require 10 hours of continuous wear. And our patients hear that message. So I'm going to give you a compliance hack that I use right now. It's called the 836. I tell my patients that their tray wear needs to be minimum of 8 hours, and they can't take them out for more than 36 hours because cytokines, the pro-inflammatory proteins called cytokines that move teeth, take 8 hours of continuous pressure on the tooth in order to be released into the body and be delivered to the site. And once you remove pressure from the tooth, they start to relapse after 36 minutes. So a lot of times a patient might think they're being compliant, but what they're really doing is they're taking a big break at dinner time to eat. So I always ask them about their dinner habits, and I get them to admit to me that they like to eat a long dinner and they like to take a break and they like to have a coffee. So I get them to admit that they're kind of cheating on the time. So I'm banging them over the head and telling them that they're not compliant, but I'm not making it their fault. I'm just telling them, you should wear the trays more often. Don't take such a break at dinner. It's not your fault. Maybe you didn't know, but you can't leave them out more than 36 minutes because teeth are going to go back to where they came from. And they all have this, they all pretend that they understand. And now they realize, I know they're not wearing their trays. I understand they're not wearing their trays, but I don't want to get into an altercation with them. So the solution to non-compliance is increase wear time and have a motivational speech. If you have tight contacts and your teeth aren't turning, you do not have enough IPR, or you're measuring incorrectly, or the IPR is not done in the right time, or it's not programmed into the ClinCheck. Please use IPR gauges in order to properly gauge how you're doing. Use non-wax floss and look for areas of tightness and rotations in order to properly correct them, okay? I'm about 10 minutes over, but I'm going to finish up in the next 5 minutes. Add appropriate IPR. Solutions to tight contacts, passive gauge, identify tight spots, proper instrumentation, proper technique. Attachments, excessive flash. You can use the blocker blacklight technique once again, and you can use these composite attachment finishing burrs from EOCA America in order to properly clean up the flash. It looks like something like this. It will not damage the attachment, okay? Here's a case that I have with too much flash that I cleaned up. Too much flash, cleaned up. Too much flash, cleaned up. Too much flash, embarrassing amount of flash. But here's the ClinCheck. Here's a progress scan on the lower arch. Yellow means not good. But after I cleaned up the flash, we got to green, and we're doing much better now. So flash can throw your case off, okay? Put enough pressure to help the tray seat or remove and redo. Attachment solution, use a munchie. A munchie is an acceleration device that helps seat the trays and promotes the release of cytokines, invented by a good friend of mine, Dr. David Penn, Sydney, Australia. We used to use Chewies, but Chewies did not keep the trays on the teeth. This is a Chewy putting force, and it would deflect the trays. Here are munchies. They have these special sections that take the incisal edge of the maxillary anterior teeth and keep the trays intact. Here's a slot that takes the mandibular incisal edge and keeps the trays buccolingually in check. And this is an extended seating arm that takes the cusp of a premolar and seats the trays and keeps the buccolingual dimensions of the trays in check. Okay, here's a diagrammatic representation. Okay, I use a red standard munchie protocol, but there is also pink and blue protocols for munchies. You can message me if you want to know the terms of those. Okay. Figure out what's best to order for your practice from EOCA America. Okay. Goals for the clear aligner portion of therapy in your office: address the patient's chief complaint. Once again, 20 trays in, 20 trays out. Minimal refinements or mid-course corrections, no posterior open bite. And realize that we have the power to change lives. We can improve health and function, but we can make a more significant difference in how the patients see themselves. Going from here to here is nice. Going from here to here is nice. This is wonderful. But this here to this here to me is priceless. A beautiful, healthy smile, as Dr. Geller states, helps someone achieve their maximum potential in life. Okay. These are before and afters, but you can't fake this. Happy, happier. Okay. Things that your patients can find: a new job, a new wardrobe, a new relationship. How about a new outlook on life? Okay. From here to here, we've seen this case before. Okay. Change your life. Align does demographic studies about who is their most successful providers. That means lowest refinement rates, number of cases started. They have an algorithm that figures out what success means. Is it male or female? Is it rural or urban? Do you have to work in a medical facility or a strip mall? Do you have to be older or younger doctor? Okay, who has the advantage? And it turns out nobody has the advantage. There's no underlying factor that predisposes someone to success and someone else to not be as successful. Okay, these are some before and afters from my patient. Let's take a look at this before and this after. That's a different person right there. Okay. My favorite case right here, this case, I say this guy looks like a frat boy, or he looks like a pirate. He looks like he opens beer bottles with his teeth, because nobody smiles like this. No one has a before picture like this, but look at his after picture. Completely warm, completely inviting, warm eyes, very inviting smile. Okay. The change in the teeth is dramatic. The change in the person is more dramatic. This is Jim. I want to show you Jim's before and afters, but I want you to know, this is my last case. I want you to note the decalcification stains on his teeth. Okay. Here's Jim before. Here's Jim after. Okay. Monumentally a different person. I happened to mention Jim. He's a personal friend of mine. I happened to mention him after my first session in Toronto with Brock. I saw him on the way back from the airport. I picked up my kid from his kid's birthday party. I said, Jim, I showed your pictures in Toronto. He says, yeah, that's fine. I give you permission. And I said, well, yeah, I already had your signed release, so I already have your permission. But, I showed your Invisalign pictures. And he says, would you show my teeth or something? Yeah, well, your teeth and your face and my face. Why would you show my face? I said, well, your face tells a story. Like before you started, you look one way, and when you were done, you looked another way. And he said, well, and you told him it was because of Invisalign? I said, yeah, I told him it was because of Invisalign. He said, well, Ron, he said, did you tell him that I was like a big alcoholic and now I don't drink anymore? And I said, no, I didn't tell them that part. He said, well, did you tell him that I was unhappily married and now I'm divorced? I'm very happy. No, I said, I left that out. Did you tell him that I was a lazy slob and now I work out all the time? I don't know, not exactly. He goes, well, what'd you tell him? Is because everything is because of Invisalign? I said, basically, yeah. I said, everything is because of Invisalign. He says, no, he said, I did it because I feel better about myself because the other good things happened in my life. I said, and I just nodded. I said, well, Jim, Invisalign was part of your success story. So I say to my doctors, lastly, energize your office. Realize that all of these pictures could be all of your patients. They're not just my patients. I didn't solicit them for their before and after pictures. They are in my patient population. A clear aligner journey, a clear aligner culture, and your patient's clear aligner journey should be part of both of your success stories. Here's a slide from Reengage that I stole from Dr. Gallagher. Said the only thing standing in your way is your story, your excuses that you keep telling yourself why you can't have this. I certainly didn't believe when I thought that I couldn't achieve this, when I thought this was for somebody else's office and not mine. I didn't believe it. I went ahead and I did it. The question is, are you ready to achieve this? I'm Ron DiRezze. This is my email, ron@shelbydental.com. If you want more information on the courses, here are the course dates. And again, kindly email lee@rondeauseminars.com for more information. And I guess I will stop sharing right now.
Ron, that was a very well done presentation. I'm so glad I went with you 3 years ago.
Thank you.
And I can't tell you how much better you're getting every time. And to be voted sexiest man in Detroit was just a fantastic thing. So we have some questions here.
Yes.
But I mean, just let everybody know that everyone's going to get a copy of this video because you went pretty quickly.
I did. And
that's
I didn't want to leave anything out.
That's okay.
Yeah.
You're trying to give a four session course.
Yeah.
Like you tried to do 4 days in an hour and a half, but
Right.
really it was well done. I mean, you certainly, anybody knows after watching this presentation that if they take your course, they're going to learn a lot.
Yes.
And they're going to do cases that they can handle and not difficult cases. They're going to handle routine cases and they're not going to get in trouble and they're going to get good results. And you say they're going to change lives.
Good.
So good for you. So very quickly, some questions. The first question, I finished a case recently that ended up in a posterior open bite. I hear this a lot from my colleagues. Is this normal? How do you fix it? And you did mention something about that.
Yeah, I went through the first cause of posterior open bite is anterior interference. There's 3 more causes. There's there's interferences cause posterior open bite, and that means molars being expanded laterally and molars being dragged forward to close a space. They can cause an interference, and there's ways to mitigate that. So there's 4 causes to a posterior open bite, there's 4 solutions to a posterior open bite, and there's 4 ways to circumvent a posterior open bite in your treatment planning. So I'm happy to discuss those, but they're passive intrusion, anterior interference, molar expansion, and mold and space closure causing mesial drift.
I know the other thing that we do with Rondeau Seminars and your courses, we have a course manual
Yeah.
for session 1 and session 2. Session 1's 2 days, session 2 is 2 days. And you've helped write that manual, of course, and you've added a lot of these things so they can see it in writing.
Yeah.
What they're getting. So everybody gets this video. Everybody watching the video gets CE credits of maybe almost an hour and a half. And that's great. So the next thing, I'm not trained in orthodontics. How should I select my cases to be safe? Because a lot of people think that ortho is a good backup. And I particularly do if the cases are really crowded. You know, put the brackets on for 3 months, get most of the crowding out of there, and then make the patient happy and finish in aligners.
Yeah.
So they don't have to have orthodontics to begin these cases. They
No,
can just be selective. If they're really crowded, refer them.
Stick to the selection criteria. Stick to the selection. No growing class 2s, no growing class 3s, no posterior cross bites, no reverse overjets, and no active perio more than 50% bone loss.
Yeah. I love your statement when you said stay in your lane.
Yeah.
In other words, know what you can do and what you can't do, and know the case are easy and the case are difficult.
Yeah.
Case selection is the number one thing in everything we do, whether it's orthodontics or whether it's Invisalign or whatever. Number 3, is there a way to change my attachments to get more anchorage? Well, you did show that very clearly. The horizontal bi-level anchorage on the bicuspids really was your secret.
Yeah, well, there's 3D controls, or you can write to your technician. There's a way to play with this while you're in the treatment planning stage to get the anchorage that you need. I go back and forth with my technicians several times on every case to get my attachments and my anchorage just right.
I think most of us, when we started, didn't know anything. And so we relied on the technicians to figure out the cases for us. And sometimes some guy in Costa Rica, who's not a dentist, maybe doesn't know as much as someone who's done this for a long time.
Yeah.
So I think it's important that we learn what we're doing. I think that's why a lot of people drop out, because they don't have the results. They don't know how to fix it. They don't feel confident. No one's going to do anything to have confidence. And that's why your course, I think, is going to give people a lot of confidence.
Yeah.
But that's great. We're certainly doing a lot more case because of you now.
Yeah.
The next thing, do I have to use all the name brand tools you mentioned, like Quick Strips or Munchies? I guess they don't have to, but they're advised to.
Yeah, they don't have to. And Brock, you've been good about letting me promote, partners that the AACA has, and these products I've recommended to you. You buy these products too, so I use them. Brock uses them. I guess it's if we use them and we can vouch for them, then you should be using them. We don't vouch for products that we don't use ourselves. So if you want to stay safe, you should use the products that we mentioned.
I agree. We love them both.
Yeah.
Number 5, the last one. Why do you want to minimize refinements? I thought refinements were a normal part of clear aligners and help finish the case. Maybe because you want to make more money.
Yeah, that has a little something to do with it. When I first started in 2019 doing this at a high level, I remember my office manager, one of the selling points of our cases was, Dr. DiRezze will do as many refinements as you want to get you happy. And I'm like, no, you can't say that. We want to try to get them done as quick as possible, not just because of the money. Refinements, although they are free, they do cost you money. They cost chair time, but what they cost is goodwill of the patient, because you've only got a very limited amount of time with adults before they start asking you, do you know what you're doing? Like, do you know when this is going to finish? So this is not a millimeter a month journey like orthodontics is. That you have to have your plan set, and it's got to be good from the beginning, because you've got 20 Ziploc bags with trays that you can't change. And you cannot eat up that goodwill by doing refinement after refinement after refinement. Patients, I don't care who you are, how good you are, patients lose interest. And when they lose interest, the second thing that goes is confidence. So you don't want to be in that boat explaining yourself why you're doing what you're doing.
And one last thing I'm going to say is that everyone who takes the course is then going to start a number of cases. And you're going to set up a virtual study club.
Yeah.
Where dentists from anywhere in the United States or Canada can join the study club, show cases, and you'll help them with those cases. So say we have 5 members of the study club and each one brings 3 to 4 cases, 3 to 5 cases.
Yeah.
Then they're going to see their cases fixed and with a treatment plan, and it can be either new or progress cases, and you'll see everybody else's cases. So that's worked for you in Detroit. You've got a Detroit study club going, but we're going to try and set up some virtual study clubs where you can help lead them on the right way so that they're going to get good results and gain confidence. So again, just confirm you're going to do that because you told me you wanted to.
Yes, of course.
Yeah. And
I'm always happy to help.
Yeah.
Thanks, Brock.
And I'm looking forward to seeing your course again.
Good.
Because I think you've got some new cases and you're turning into a great teacher. And again, I'm glad you won the award. Congratulations.
Thanks.
And you did a great job with the staff. Apparently, only 50 out of about 450 fell asleep, which is better than my courses when they half fall asleep. So anyway, thanks very much. Okay.
Thank you, Brock.
Bye-bye.
Bye.
Bye, everybody.
Thank you, everybody.